Hi, my name is Christina, and our group decided to do our case study on traumatic brain injuries. Accompanying me is Kelly McIntosh, Lisa Snyder, and Kimberly Wasson. So some normal functions of the brain include the frontal lobe, which includes problem solving, recognizing emotion, or regulating emotion and social skills. We also have the brainstem that regulates breathing, body temperature, and heart activity. The cerebellum controls balance and muscle coordination, just to name a few functions of the brain. So some traumatic brain injury facts. A traumatic brain injury occurs when there's an external mechanical force that causes brain dysfunction. Some more serious traumatic brain injuries can result in bruising, torn tissues, bleeding, or other physical damage to the brain that can result in long-term complications or even death. Some signs may appear immediately after the traumatic event, or while others may appear days or weeks later. Some common causes of traumatic brain injuries includes falls, where the patient falls out of the bed, they're slipping while they're getting out of the bathtub, or they fall downstairs, etc. We have vehicle-related collisions, which involve cars, motorcycles, or even bicycles. Some sports injuries can cause traumatic brain injuries from sports such as soccer, football, boxing, etc. So here's a graph of our statistical data. As you can see, the highest percentage is from falls. That's more likely with our elderly population, followed by 20%, which includes traffic accidents, just to show you a brief demographic. So risk factors. The people that are at most risk for traumatic brain injuries include our children, newborn to age 4 years of age, young adults, which is our teenagers, starting about age 15 to 24, really don't pay attention when they're driving, more or less. We have our adults, or more like our seniors, where they're 75 years or older, where people are not wearing their seat belts, or if the airbag hits their face and causes injury that way. Sometimes, a lot of the times with the motor vehicle accidents, alcohol or drug abuse may be involved. And then, of course, not wearing your helmets.
Hi, I'm Kelly. So I'm the nurse on duty, and we have a report from dispatch that a 34-year-old female that's riding home from being out to dinner and a movie with her family, traveling home, she's the passenger, they're going about 65 miles per hour when they are T-boned on her side. Rescue gets on the scene. She has a GCS of 14 because she is confused. She also has profuse bleeding out of both of her ears. She's being flown in by the trauma hospital, and she's coming to our level 1 trauma center. When she arrives into the trauma center, some things that we would be concerned about is her history. She has a history of tonsillectomy. She had a C-section. She has no known drug allergies. She does not take any medications. She's a non-smoker, non-drinker. So when she gets into the trauma center, our biggest concern right now, just by her GCS of 14, her altered mental status, and the bleeding from her ears, is to rule out a traumatic brain injury. Orders that the physician would place is for her to have a STAT CT scan of her brain, which we would need to do within 30 minutes of arrival. We would do some laboratory work, which would consist of a CBC and a type-in screen. We would do a 12-lead EKG. We would provide cervical spine precautions if it wasn't already applied en route, which it should have been, because if she hit her head hard enough to result in a traumatic brain injury, she could have a spinal fracture. And we're also going to monitor seizure precautions, because that's very common in traumatic brain injury patients. So on our initial assessment with her, you can see that her vitals, she's normotensive at 114/71. Her heart rate is a little tacky at 119. She's got a respiratory rate of 20 on 2 liters nasal cannula. She is sat at 98%. She has a temperature of 99.1. She remains a GCS of 14. She's disoriented, and she still has the profuse bleeding from her ears. As the nurse, we would attach her to the monitor. We would start 2 large bore IVs. We would draw labs and send them off. We would gather x-rays, which would consist of chest x-ray, pelvis x-ray. We would then get her to the CAT scan area stat. We would also make sure that if any of the doctors needed to be told of any immediate results, that we would let them know as soon as possible. So now is our time to think. Given the current information, what do you think is the most important thing to assist with the diagnosis of this patient? What would you do first, and what would be an ongoing priority? If you answered emergent head CT, you are correct. Like I said, the patient should be in CT within 30 minutes of arrival. Also focus your assessment on neurological status, neurological exam, signs and symptoms of any intracranial pressure, monitor her GCS score, and seizure precautions.
Hi everyone, I'm Lisa and I'm the trauma nurse that took her to CAT scan. So our patient actually decompensated during CT. She had a seizure and she lost consciousness. She was immediately returned to the trauma center for intubation, and the head CT revealed subarachnoid and subdural with a midline right midline shift. So our physician orders, we're going to consult neurosurgery. We're going to monitor oxygenation, of course, monitor her vital signs, monitor her neurological status and her GCS, make sure she has seizure medications on board, mannitol bolus if needed, and we're going to repeat a head CT when she is stabilized. Her current assessment is her blood pressure is 110/54. Note her heart rate. She's bradycardic. When initially she was 119, so she was tachycardic. Respiration is 18. Her stats are 99. Her GCS is 5. She has a 1 for eye, a 1 for verbal, and 3 for motor. Pupils are unequal. The left is larger than the right, and she is having intermittent seizure activity. So our evidence-based nursing interventions, we're going to expedite a repeat head CT, ongoing neurological assessment, medications per order, monitor EKG, monitor her vital signs, I's and O's, and monitor her serum sodium and potassium. So now it's time to use our brains. What are some other variables that can affect cerebral oxygen demand? What are some interventions the nurse can do to treat these variables? Did you know brain hypoxia is the #1 reason for poor outcomes in TBI? Other variables that can affect cerebral oxygen demand include fever, shivering, pain, and agitation, and the nurse should monitor for all of these.
Hey everyone, I'm Kimberly Wasson, and now we're at repeat head CT. We've got the results in. This is stage 3. The head CT results show hemorrhagic contusions with increasing hemorrhage, along with increasing diffuse subarachnoid hemorrhage. Neurosurgery was notified of the results. Physician's orders at this point are neurosurgery at the bedside to place external ventricular drain, EVD is what we call it, placement. Monitor ICP per neurosurgery's orders. Monitor proper zeroing, placement, stability, sterility, and integrity of that EVD. Keep the mannitol to keep the ICP less than 20 mmHg. Sedation, typically it's propofol for neurosurgery type situations. Monitor your neurological status and GCS. Monitor that oxygenation, vital signs, and prompt report of changes to the MDs. So, post-procedure, this is post-neurosurgery at the bedside, placing that drain, the EVD. Vital signs, you can see huge improvement. The blood pressures kind of remain the same, but the heart rate is now stable. Huge improvement. Respirations are 18. You got your oxygenation at 100%. Of course, the patient is intubated and mechanically ventilated, so we can control that. Temperature is 98.9. Your ICP is 12 mmHg, less than 20. GCS, of course, remains at 3. The patient is heavily sedated. Huge improvement here. The pupils are 2 mm's, bilaterally with slight reaction, no seizure activity noted at this point. So some evidence-based nursing interventions, ongoing comprehensive neurological assessment. That is huge in these patients at this point. Monitor that blood pressure, definitely that oxygenation. Maintain hyperosmolar therapy with the mannitol. Monitor the ICP. Maintain your sedation. Monitor intake output. Anti-seizure prophylaxis. Infection prophylaxis at this point is huge. DVT prophylaxis as well. We don't want any complications in these patients who are already suffering from many, many complications. So we have a little brain teaser here for you. What is the pathophysiology of a subdural hematoma versus your subarachnoid hemorrhage? And what is the nurse's responsibility for the EBD versus the ICP monitoring? So here you have a picture of a CT of a subdural hematoma, and until I did this project, I didn't even realize that it was 60 to 80% mortality in these patients. What it is a tearing of the bridging veins and Powell artery or cortical veins, and it's acute versus a chronic situation. Our patient has the traumatic subarachnoid hemorrhage as well. And what that is lacerations of the vessels in the subarachnoid space, which you can see here on the CT that we put up for you. The EBD and ICP monitoring, the nurses should ensure proper zeroing, placement, sterility, integrity of that collecting system. ICP waveform, which you can see here, we are responsible for analyzing and the close monitoring of the CSF drainage. It's extremely important for the clinical outcomes of this patient. Once again, if you learn nothing else from this presentation, ICP should be less than 20 mmHg. Boom, right there at 15. These patients have a long road ahead of them. Recommendations for the road to recovery. Most people who have had significant brain injury, they'll require some sort of rehabilitation. Usually it's pretty lengthy. They have to relearn basic skills like walking, talking, reading, writing. The goal is to improve these abilities to perform their activities of daily living. Therapy usually begins in the hospital. Some of these folks go to rehab facilities, inpatient units, residential treatment facilities, or other type services. The type and duration of rehab, it depends on the individual and also the severity of the traumatic brain injury and what part of the brain suffered. This is definitely a whole nother case study. And at that, we're going to end. My team members here, Christina, Kelly, Lisa, and Kim.
Thank you.
Thank you.
Thank you.